Hello everyone, today we are going to be discussing pancreatitis. An angry pancreas is a pretty scary thing, and this is reflected with an overall mortality of about 5%. In fact, in severe disease, this increases to up to 35%. So knowing the high-yield history and physical exam for pancreatitis is really important. These patients will often present with rapid onset epigastric or left upper quadrant pain that radiates to their back. It's often very severe. It's going to be associated with nausea and vomiting in most cases. Whenever you go in and talk to these patients, you're going to want to ask questions about history of gallstones and if they've had a recent ERCP. Sometimes pancreatitis is iatrogenic, meaning we caused it. I actually saw a couple cases of this while I was on emergency general surgery. So this is always something you want to keep in the back of your mind. You also want to ask about hyperlipidemia and alcohol use. Next, get a thorough med list because lots of medications can actually cause pancreatitis. And you're going to want to ask about trauma. Trauma can always cause pancreatitis because if you get hit in the abdomen, it can make the pancreas pretty angry. And this is actually the #1 cause of pancreatitis in the pediatric population. In physical exam, you're going to want to check their vitals. You're going to want to see if they have SIRS criteria, meaning fever, tachycardia, and hypoxia. These are often present if their disease is severe. You're going to see epigastric tenderness and jaundice potentially, but importantly, they'll likely not have peritoneal signs unless they've had some sort of rupture or lots of free fluid in their belly. If they have hemorrhagic pancreatitis, they might have Cullen sign or Gray-Turner sign. There are a couple different ways to remember this. Some people remember Cullen, the U sound, meaning umbilical for periumbilical ecchymoses versus Gray-Turner for flank ecchymoses. This is a little confusing to me because both have U's. So I actually use the Board Bombs EM podcast to remember this rule. They say that Gray-Turner has 2 words and you have 2 flanks, and Cullen only has 1 word and you only have 1 umbilicus. So this has worked pretty well for me, and I encourage you to find one that works for you because this comes up a lot in tests. The differential diagnosis for acute pancreatitis is pretty extensive, as you can see. The important thing here is not to get tied down into just abdominal disorders. You want to remember that there are problems that happen in the thorax, like MI, pneumonia, pericarditis, or different effusions. And they might also have systemic disorders that can present like this, like sickle cell crisis or DKA. So you don't want to anchor to only the abdomen, and you certainly don't want to anchor to only the GI system. As always, your diagnostic testing should reflect the differential diagnosis you've created. So you're going to want to get a CBC, a BMP, LFTs, a lipase. You probably don't need an amylase. Lipase is more sensitive and specific because amylase can be elevated if they have different esophageal pathologies or different intestinal problems. Lactate if they have really severe disease. ALTs or liver enzymes, just because these will probably be elevated if they have gallbladder pathology. And you'll also want to consider getting blood cultures if your patient is really sick and you have concerns for pancreatic necrosis or extrahepatic infection. And getting a blood culture before you start antibiotics is a really important step in their management. You're also going to want to get an EKG because MI is on the list and you got to rule that out. Then for imaging, you're going to get an ultrasound because you want to identify if there are gallstones present and if they have a dilated common bile duct. 3 millimeters at 30 years old is pretty much the standard, though this can change from person to person, and then you add 1 millimeter for each decade of life after 30. This is something that comes up all the time on tests, especially your surgery shelf, so this is a good thing to know. Imaging continued, if you need more information, you can get a CT scan. Typically in books and on tests, this is only needed for the evaluation of necrosis, which normally only presents after 72 hours. However, in the emergency department, your patients are often undifferentiated, and the diagnosis of pancreatitis might not be a slam dunk, so you might end up getting a CT scan anyways. A chest x-ray is indicated if there's a concern for pleural effusion, and sometimes these patients are complaining of pain that's tough to differentiate between intrathoracic or intra-abdominal pain, so you might end up getting a chest x-ray anyways here also. Diagnosis of pancreatitis requires 2 out of the 3 following criteria: abdominal pain consistent with the history and physical exam we discussed before, lipase greater than 3 times the upper limit of normal, and characteristic imaging of pancreatitis. The classic imaging is shown in blue on this slide. The shaded blue shows extrapancreatic fluid and fat stranding, which is very characteristic of an angry pancreas. Management of these patients is something you hit pretty hard during your clerkship years. You're going to want to make your patients MPO and start IV fluids. The important thing to know now is how much IV fluids you want to give your patients, and it's a lot. 250 to 500 mils an hour of lactated ringers while they're in the emergency department, and you can reassess your resuscitation by checking their BUN and creatinine within 6 hours to see if you have stabilized those numbers. It's important to know that fluids do actually have consequences, so if your patient has some contraindication to getting lots of fluid, like congestive heart failure, you want to definitely talk over with your attending how much you're actually going to give them. Consider giving them different electrolytes based on their BMP. The most likely one you're going to be replacing is calcium because of saponification, if you remember all the way back to your basic science years. So be ready to replace some calcium in these patients. Next up, you're going to want to control their pain and be on the lookout for persistent nausea and vomiting. You're going to want to use narcotics and Zofran most likely as your first line agents in managing these problems. Next, you're going to want to consider extrapancreatic infection or necrosis. Both of these require that you give antibiotics, and these make their diagnosis really severe. Definitely consult the EMRA antibiotic guide, and this is something that you're going to want to talk over extensively with your attending. Next, if you suspect that it is a biliary cause, if you did an ultrasound and you found a dilated common bile duct, you're going to want to do an early ERCP if it's acute cholangitis, or an MRCP to assess for choledocholithiasis. So you diagnosed your patient with pancreatitis and you're managing them well. What are you going to do with them? If they're uncomplicated, they can go to the floor. You might consider ICU admission if they have persistent surge criteria, if their age is greater than 55, or they're an obese patient with a BMI greater than 30. If their hematocrit is greater than 44, they're hypoxemic, they have a rising BUN or creatinine, really any signs of systemic hypoperfusion or just general badness is going to make you consider calling the ICU. Also, if they have intrathoracic problems like pleural effusions, or if they have extrapancreatic collections, lots of them fluid in the belly or pseudocysts is something that's going to bump them up to a more severe category as well. These patients are rarely DC'd from the emergency department, so return precautions aren't super common, but if they develop high fevers, they have even more severe pain, they should definitely come back. Now it's time for our fast facts and practice pearls. Our classifications for pancreatitis are mild, moderate, and severe. They're mild if they don't have any signs of organ failure. They're moderate if they have signs of organ failure for less than 48 hours, and severe if they have greater than 48 hours of organ failure. It's important to note that there are lots of scoring systems for pancreatitis, but none are very good at accurately predicting the disease severity of these patients, and while you can use them to help get your patients admitted to a certain place if you think they need it, just know that it's not, those scoring systems aren't actually very good at prediction. The next thing is that though this might not affect you in the emergency department unless you're boarding lots of patients, these patients can eat early. Though you want to make them NPO just to give them bowel rest and give the pancreas some time to rest, as soon as they're hungry, they can start to slowly advance their diet. This is a change from past practice, but it's just a good thing to know and likely a question you'll be asked on the medicine wards or even in the emergency department. Then finally, just good things to know, especially for tests and diagnostic purposes, are the local complications that can occur with pancreatitis. Peripancreatic fluid collections, necrosis, and pseudocysts are going to be the big three you want to be on the lookout for. You'll most likely diagnose these with imaging, and if for some reason you get imaging when they come in that identifies one of these, this might change how you manage it in coordination with the admitting team because they might be headed to interventional radiology to train some of this. Pancreatitis is a really important diagnosis to know a lot about. It comes up all the time on different tests. It comes up all the time in clinical practice, and it's something that you need to be pretty comfortable with the management and disposition of. So I learned a lot by using these resources, and I think that you'll enjoy them too. I encourage you to read as much as you can about this because it's something that's going to come up a lot. As always, thanks for listening.